So some of these are sort of common compliance pitfalls. And I'll say that obviously I think one of these I shouldn't even have to be mentioned, but I'm going to because we see it over and over and over again from programs that we're either helping out or taking over. First off, 2-day waiver rule. We talked about this already. Again, if you're getting less than 16 days of physiological vital readings, you really should consider whether or not to bill for it. And I think you should not bill for it. That said, there's an exciting thing. 2026, the AMA is proposing 2-day RPM codes that are separate from the 16-day codes. So this might change. But for now, don't jump the gun. That's a big thing that we're seeing. And we're seeing a lot of providers say, well, no, I was told you could do it with 2 days, or I was told you could do it with notifications. But if you get 5 days, make sure you have 16 days in a 3-day period. It's a pretty important aspect of the codes, given that is pretty much the whole aspect of the codes. Don't bill for dead people. And if you bill for dead people, don't do it again. We're seeing a lot of programs where this is more an issue with CCM than RPM, because RPM has that interactive communication requirement. So if you're calling and talking to the patient, they're hopefully not dead, right? Given that. And because of your care management services, Medicare expects a certain amount to die in the later part of the month when you talk to them earlier, and that's kosher. You can still bill for that, right? You put the data service as the last interactive sort of date, or when you hit the time, and fair enough. One way to get an audit, or at least get scrutiny pretty quick, is to have a high percentage of dead patients being billed for this. So if you have 454 and you have readings coming in, this is especially the case where people are counting notifications. If you're texting dead patients and billing for it, and they only get 2 or 3 measurements or no measurements, you better make sure that it's not going to come back that they were either maybe inpatient, maybe they were in the hospital and it was impossible. They don't have to be dead, right? It just has to be non-covered periods. But again, beware that happens more often than you would think. And then also, one part of the code set for RPM is that you have to have basically, if there's a more specific code that you can use, you're not supposed to use the RPM codes. So if you have a Holter and you are using the Holter codes normally, but there's you don't hit the critical mass of required whatever for Holter, you can't fall back to the RPM codes. If the device has a more specific code, you're not supposed to use the RPM codes. This is a little odd where you have spot ECG, where maybe you're using it going forward anyway after, maybe you're doing a MCT or Holter study for 30 days, and then you post ablation, and then you're doing an ongoing sort of spot ECG. That's okay. But just be cognizant of, at least, are there codes that are more specific that you can use under this criteria? That is something that is a little more, there's some debate on when that really applies and how that applies. And it's good faith debate, to be honest. So things like, can continuous blood glucose be billed, even though it has another code? Well, maybe it can if you're using it, I don't know. Again, just know that you're taking a bit of a risk, and sort of, that's a risk versus reward thing as far as how that works in the devices that you're using. So real quick, 2 more slides, then we'll go to QA. The one thing I really do want to mention is sort of folks who are outsourcing and how that plays into the recent changes of the waivers and things like that. There's 2 types of outsource models. So first off, there's obviously a version 0 here where you do it yourself. You're doing it yourself. You're the provider. Off you go. You have a software that's usually tracking it, and you're doing the care management time and checking the measurements, yada yada. In the OIG report, they cited 21 vendors who they're like, this doesn't look right. And looking at those vendors, they are using what we call the vendor is the billing clinic model. So there's 2 models for outsource. One is, you are the clinic, you hire us, we do this, right? You hire us, we have a care management team that we put together that helps manage your program as an agent of the billing provider. So there's coordination, there's ongoing, I usually say, if you're doing it yourself, we're helping you with 10% of the work and you're doing 90% because we're the software vendor. If it's outsourced, we're doing 90, you're still doing 10. There is a no good situation where the provider is doing 0 or 1 or 2% of the work, right? That's where you'll come awry of these things. Vendor as agent means there's an escalation criteria to the provider. It is still done by the provider who has the established relationship with the patient. The vendor as a billing clinic model is different. It's basically a referral agreement where I'm the vendor. I have a doctor or a provider who I'm billing under, and you're referring your patients to me. In vendor as agent, you're getting an invoice from the vendor saying, hey, we did all this work for you. Hopefully you billed for it. We can help you if you didn't, but here's what you owe us for the time and effort, what we did. Vendor as billing clinic model, you refer the patients, the vendor bills for it under their doctor, and then they I almost said kickback, but it's not that would have been too telling. They pay back some of that money to the provider that referred the patient. And the way that they say this was a collaborative, practice that we're billing for it, but we're working in collaboration with the active provider. I will say this is much harder to do, I would expect, after the established patient rule was the waiver was taken out, because I don't know how you have an established relationship with the vendor that just says RPM. I believe that's why the OIG cited those 21 companies as like billing for tons of RPM without really clear visibility. I think that is the model that is going to have the most scrutiny. They are the ones that stick out because suddenly you see a doctor in Florida who's part of an RPM company who's billing for 20,000 patients, right? And doesn't have necessarily in-person visit relationships with any of them, right? You don't necessarily need an in-person visit. You just need to establish a patient relationship. But the numbers are high enough where you start getting this thing where people start looking, right? And part of this is to avoid the scrutiny versus just, passing the audit at the same time. So anyway, something to look out for. I think that's going to change, or at least that's going to be a big target. I know we're a little over, so I'll move on. But yeah, important sort of balance to think through when you're deciding whether to outsource, in-source, or what kind of outsource you want to do.